Right, excellent. So again, welcome everyone. My name is Kara Kaikini. I use she, her pronouns, and I'm the board president of the Maine State Breastfeeding Coalition. And first, I'd like to acknowledge that here in Freeport, Maine, I am standing on Wabanaki and Abenaki territories. And if you're interested in learning more about the Indigenous territory you may be standing on, you can check out the website here on the screen. And I think Amanda is going to drop that in the chat box as well. So we want to wish you all a happy World Breastfeeding Week, the theme of which is to step up for breastfeeding, educate, and support. And that is what we're doing here today. And the objectives of World Breastfeeding Week this year are to inform, anchor, engage, and galvanize. And I encourage you to read those, and you can find out more at worldbreastfeedingweek.org. And if this is your first introduction to the Maine State Breastfeeding Coalition, welcome. Thanks for being here. The MSBC is a nonprofit that became established as a 501c3 in 2017. We have a board of 11 incredible leaders, and our vision is that when every baby receives human milk, we'll be a healthier Maine. And our mission is that we are a welcoming and broad network of people supporting families who value human milk and breastfeeding. And together we work to enhance the culture of breastfeeding around the state through professional networking, advocacy, and education. We have several committees, and we're always looking for volunteers. So if you're interested, please fill out that form. Amanda will put that in the chat box at some point here too. And by attending today's webinar, you're automatically entered into our raffle for a $100 Visa gift card. If you'd like to increase your chances of winning, and if you'd like to support the Maine State Breastfeeding Coalition, you can purchase more raffle tickets through our Venmo account. You're also welcome and encouraged to make a donation at our PayPal page too. Every drop counts, as we say in the breastfeeding world, but also in the donation world for nonprofits. So thank you for any support you can offer. Speaking of support, we want to take a moment to thank our supporters, our sponsors. We have annual patron partners, supporters, and advocates, and some event supporters as well. So they're helping to make this webinar series possible, in addition to help us reach our mission and other strategic plan goals. So thank you to all of our sponsors. And we're excited to kick off World Breastfeeding Week with a third of 4 free educational opportunities. If you've missed any, you can find the recordings on our YouTube page. Otherwise, we hope to see you tomorrow at our coalition meeting for another great educational opportunity that's focused on supporting and empowering solo lactating parents. The second half of our meeting will be on connecting and sharing updates from around the state and the nation. I know we'll have some special guests from the Paid Leave Coalition of Maine to share an update about paid leave efforts, as well as someone from the United States Department of Labor who will give a brief update about workplace rights. So we hope that you'll be able to join us for that. And for today, I'm really excited to welcome our panelists. We have Dr. Stephen Maturo from Maine Medical Partners Otolaryngology, Dr. Kelsey Walton from Kennebec Pediatrics, Paula Norcott, IBCLC from the Maine Mothering Company in Brunswick, Dr. Mike Dowling from Dirigo Pediatric Dentistry,
we see 1 to 5 patients a year. But we really started seeing a lot of probably about 8 or 9 years ago. So that's when it really became, and over the past 5 years, it's become really popular in the ENT literature and ENT meetings. Just got back from a pediatric ENT meeting a couple months ago, and they had a whole hour-and-a-half talk about tongue ties. So this is kind of really come to the forefront of pediatric otolaryngologist experience. I think my experience with parents bringing their children in for concern for tongue tie is, parents are confused, they're anxious, they've been told conflicting things, and most of them have not seen a lactation consultant. So it's really it's kind of a high anxiety appointment for all those involved. And especially, and we'll talk about as we go along, is that the literature is just not that great in terms of long-term results with tongue tie in breastfeeding. So that's been my kind of overall experience, just from a 30,000-foot view of parents bringing their children in for tongue tie. How do I assess for tongue tie? For me, it's the same thing every time. History and physical, the child was born, history of prematurity. If they've seen a lactation consultant, if they have any airway concerns, if there's any family history of bleeding disorders, because if we're going to go down the road of doing an in-office frenulotomy, I want to know if there's a history of bleeding disorders, or if there's any history of any airway obstruction. In terms of my exam, I do a full ENT exam, palpate the floor of the mouth, look at the tongue, do a good oral cavity exam, make sure the child is not retrognathic or micrognathic, because with that child who has a tongue tie, that may be pulling their tongue forward and preventing them from having airway obstruction. And then I am not obviously not educated. I do not have the background in terms of assessing breastfeeding and the knowledge of that a lactation consultant would have. So that's one area that I lack in, that I probably could improve upon. But I don't have the right now the time to learn as much, and I put a lot of faith in my lactation consultants who do refer to me, but that's kind of few and far between. The other issue here, we're kind of going by a list that Kara said, is talking about posterior tongue tie, and that's if it's been 10 years where we started seeing a lot of tongue tie, it's only been in the past 5 to 7 years where we've started talking about posterior tongue tie, and I still struggle to define it. I guess I define it as it's posterior tongue tie is not anterior tongue tie. I mean, anterior tongue tie, it's pretty easy to diagnose. The frenulum comes to the tip of the tongue. But otherwise, if the frenulum looks like it's kind of in a normal position, but it may feel a little bit tight, I think that's what a lot of people diagnose as posterior tongue tie. It's not based on any anatomic abnormality. So, and I really struggle with posterior tongue tie because the literature is not great. There's not really a lot of good prospective studies. You're just in treating it, you're just kind of blindly cutting the base of the tongue. And I'm not really sure in a lot of instances that it's beneficial. So that's something that I struggle with. And I think a lot of pediatric ENTs struggle with. And the other thing we've talked about that's even more like in the past, maybe 3 years is upper lip tie. And there's even less data about upper lip tie than posterior tongue tie. There's conflicting. I'm not a dentist. I'm just going to hear Dr. Dowling's thoughts, but I've heard of conflicting reports that you never want to treat one of these because it can affect the child's permanent adult dentition towards, it is okay to treat this. But I would say that there's very little literature in the showing that upper lip tie improves breastfeeding function. And I rarely address this, although some of my pediatric ENT colleagues in the country have good anecdotal evidence that it is successful, but I just, I haven't seen the data to support that. Just kind of going down the list in terms of explaining the increase in tongue tie. Well, I think it's through efforts to increase breastfeeding. I think that's number one. And then also social media. I think, between Facebook groups, parent groups, mother groups, that people can find the information and it's easily accessible. So I think that's there's in certain parts of the country, they've seen a 4-fold increase in children diagnosed with ankyloglossia or tongue tie, and a 2 to 3 time increase in frenulotomy. So it's really questioned: are we, over-diagnosing and over-treating this condition? And I don't have the answers. Hopefully, we can have more studies in the future that will look at this. But I think that's why we're seeing a lot more increased incidence. And then I think, the last 2 things in terms of, what do I wish people know about breastfeeding, and how do I counsel families? I think I sum it up to parents saying that, if the child does have tongue tie and mom has breast pain, or there is some concern about difficulty feeding, that I'm willing to to do a frenulotomy, but I just say that I can't guarantee that everything is gonna improve. It's a very low risk procedure. In children under the age of 6 months, I'm willing to do it in clinic. But also that not every child with tongue tie needs to be treated. The children who are feeding well and gaining weight and mom's not having any breast pain, nothing needs to be done. There's been no studies to show that treating tongue tie helps with speech in the future. And the majority of children that I see in clinic who I'll just find an incidental tongue tie when they're 10, 11, 12 have never had any speech issues. So I think it's for us providers that treat this, I think it's a shared decision-making model where we just kind of lay out the facts. And I think hopefully parents feel comfortable then with the decisions that they make. So thank you for your time. I'll turn the floor over to the next speaker, and thanks.
Thank you so much for all that. We have some questions coming into the chat, but we will leave time at the end for Q&A. So Dr. Walton, do you want to go next?
Sure. Can everybody hear me?
Yeah, we can hear you.
All right, good. So I am a pediatrician. I worked for the last 9 years as a pediatric hospitalist in Maine. I'm mostly taking care of newborns and some older kids, but largely taking care of newborns. Recently, I transitioned to primary care about a month or two ago. So now working as a primary care pediatrician in the Augusta area in Maine as well. So I have a fair amount of experience dealing with newborns, feeding and breastfeeding trouble. And so I'm excited to be here. So going down the list here, so my assessment, what I typically do for newborn feeding assessments, for me, the bulk of assessing for tongue tie is in the history. And so largely what I do is talk to parents about, and mom, about symptoms of tongue tie. So pain with breastfeeding, shallow latch, popping on and off the breast frequently, difficulty transferring milk, feedings that take an hour or 2 hours at a time, all of those sorts of things. If I'm lucky enough to have the time, I love to see a latch or talk to the lactation consultants I work with, just to assess how things look from that standpoint. And then really the I think least important part of my assessment is my exam, because for me, babies have frenulums under their lips and their tongues, but really what I want to know is how they function. And that's in the book, that's mostly the history. As part of my exam, probably the most important part of my exam, I like to kind of do a suck assessment. So have baby suck on my finger. What does that suck feel like? How is the tongue moving? Try and think about the posterior tongue versus the anterior tongue. Is that posterior tongue moving at all on my finger? Because oftentimes with tongue ties, they don't. Do I feel clicking against my finger? Is the baby able to get that tongue out over that lower gum line? How high is the palate? Do I have a baby with a very high palate or a normal palate? Because high palates are often associated with tongue ties. And can affect how a baby can latch. Because if they can't bring the tongue up against that palate because of a tongue tie and a high palate, obviously they're going to have difficulty getting a nice deep latch. And then really the minority of what I do is look at those frenulums. I usually take the baby with the head on the bed towards me and try and lift that upper lip up towards the nose and try and assess how stretchy that upper lip frenulum is. And then I get a look underneath the tongue. I kind of do a sweep, feel how loose that tongue is and the posterior part, how much anterior frenulum do I feel? And then I try and elevate it and see how high I can elevate it. So that's really the bulk of what I do for assessment. And then mostly, if my exam is totally normal, but I still have a mom who's having significant symptoms of tongue tie, I still would probably refer for an assessment for a revision for that baby. So really, like I said, the bulk of my assessment is in the history. And then if I have a baby who's also bottle feeding, if I'm lucky enough to have the time to bottle feed that baby as well and see how that baby bottle feeds, are they losing a lot of air, swallowing a lot of air? What sort of nipples has mom tried? Can the baby take a pacifier? Because oftentimes breastfed babies won't take pacifiers. They're super gaggy. So it's the cumulative symptoms that I see can push me one way or the other as far as referring for tongue tie revision. So cases when revisions are necessary, I think those cases are the cases where I'm seeing a lot of symptoms. Oftentimes, I think that I agree the anterior tongue ties where they come out to the tip, those are easy. Most babies are having symptoms anyway. But cases when revisions are not necessary. So where exams, you see a frenulum under there, but there are no symptoms, I won't refer those babies. I've had parents ask me to refer because they're worried about speech in the future. I won't refer those babies either for revision. Largely, like I said, it's symptoms. And then really on my assessment, I'm also looking for any other reasons why baby might have difficulty feeding. So recessed jaw, do I have a preterm baby who is very sleepy at the breast and that's why they can't sustain a latch? What's the medical history? Am I worried about infection or other medical complications from the baby that make me worried about this baby's feeding that aren't related to a tongue tie? Let's see, how do I explain the increase in tongue tie diagnosis? I agree. I think as breastfeeding is becoming more common, I think we're diagnosing more tongue ties. I think the diagnosis is difficult a little bit, and partly probably why we're having a lunchtime talk about this, because there's really not a whole lot of data on how to accurately assess these kids. So there's not like a scoring system where you can say, definitely this baby has a tongue tie and this baby doesn't. I think of it more of like assessing headaches, right? In older kids, I'm asking about the symptoms, and when you feel like something is consistent, then we're making a diagnosis. And I think that's hard to, there's not a whole lot of literature on how actually to do that in babies with tongue tie. I don't typically use the scoring systems that are out there as far as grading of a tongue tie because there are too many of them. It's too confusing for me to remember all of them. And I feel like in between us and lactation and the surgeons who do the revisions, there's too much, it's too subjective and not objective. As far as, back to tongue tie diagnosis, I agree. I think parents are becoming more savvy about learning about tongue ties on their own, partly because I think that there's a lack of knowledge in the medical world about it and a lack of advice about it as well. As far as posterior tongue ties, so I agree. There's not a whole lot of data about posterior tongue ties in relation to symptomatic tongue ties. And there's really no way there's no standard to say a posterior tongue tie equals X, Y, and Z. So a lot of times when I say posterior tongue tie, I'm mostly talking about like a submucosal tethering. But that is different depending on, what system of grading tongue ties you've been educated on. I do feel like posterior tongue ties contribute a lot to feeding difficulties in babies because number one, they're often missed because they're not blaring in your face on your exam. And number two, that posterior tongue is so important in the function of feeding that the tighter that is tethered down, I feel like it seems that the more dysfunction we're seeing in babies who are breastfeeding. And then upper lip tie, I also agree. There's really not a whole lot of data on upper lip ties. I have seen upper lip tie revisions work and I've seen them not work, but certainly I don't quite know. I've heard conflicting evidence about the dental contributions of revising upper lip ties as well. So I'm curious about what Dr. Dowling says. But I have also seen a handful of older kids in my practice who have had significant dental decay from upper lip ties. That's unrelated, but And then moving down the list, so I'm trying to keep this brief. I could talk about tongue ties all day. What do I wish that people knew about tongue ties? I wish that people took mom's pain seriously and really asked more questions about it in assessing breastfeeding infants and dysfunctional breastfeeding dyads. And what else did I want to say? What do I say to overwhelmed parents who are getting conflicted messages? I really like to do shared decision-making with parents, really put the data out there about the pros and cons of revision, not revision, diagnosis of tongue tie or not, and really trying to empower them with the knowledge to feel comfortable in making these sorts of decisions about where to go with their infant. That's the start. I think that's everything I have to say.
Awesome, thank you. And sorry about my computer crashing at the most inconvenient time. Thank you so much. Actually, I know that I just sent Amanda. Can you tell me who's up next? Or if you know that you're up next on the list?
Yes, it's Paula.
Thank you. I need to pull that up. Paula, you're up. Please introduce yourself, and you've got 5 to 10 minutes.
Awesome. Hi, everyone. I'm super excited to be here. I see so many awesome familiar faces. Hi, friends. I'm an IBCLC. I have previously worked full-time at Maine General with the lovely Kelsey. I also have been per diem for years at Midcoast Hospital, but I'm primarily in private practice at Maine Mother and Company in Brunswick. Been working with feeding families for about just over 20 years. Got my start in Massachusetts. My experience with tongue ties is that my private practice is predominantly becoming tongue tie based. I think I'm kind of building a reputation around people struggling and working with other professionals and not quite getting to where they want to be and coming to see me. My appointments with my patients are over an hour long typically, so I get to spend a lot of time with them, which is kind of unique in the medical professional world because billing. So typically I get an hour with my families, which means I get to spend a lot of time hearing from the feeding parents exactly how feeding's going. How do I assess? So symptoms for sure. The biggest red flags to me are a baby who can't transfer milk effectively. So slow weight gain, but with a great supply. And even sometimes slow weight gain without a great supply, because if a baby isn't pulling milk effectively, that body is not getting signals to increase volume. And so they kind of work together. Pain with latch is a huge one. I think it's brushed off a lot of times. I think there's a lot of misinformation that breastfeeding is supposed to hurt, and it absolutely is not. If it did, none of us would do it. I do an oral assessment. It's technically out of my scope of practice to diagnose a tongue tie. So what I'm really working around is these symptoms could potentially indicate that there's tight oral tissue and that you should have an evaluation with a pediatric dentist or an ENT. So that's sort of my step. We pay a lot of attention to a suck-swallow ratio, which is something that I think a lot of other medical professionals don't necessarily know, is that a baby can look like this and not be moving any milk. And so this is one of the big struggles we see with families, and why things can take a long time before we see what's happening is because when a parent is watching a baby feed, everything looks fine, and they don't realize until they hit their 2-week mark and their baby's not up to birth weight yet that there is a problem. So that's a lot of times when we're seeing them. When I see newborns in the hospital, I might mention to a family if I notice some things: clicking, slipping, slurping, leaking. These are all potential tongue tie symptoms. Pain with latch, God forbid, nipple damage. So I might say like, hey, if these symptoms aren't going away, you might want to come back and see us. The cool thing is that the Affordable Care Act mandates 6 lactation visits covered by insurance. And so those of you working with families should know that it is mandated that their insurance cover a visit. And most of the local hospitals will see you, even if you haven't been a patient there. So that covers home birth communities as well. a case when, so this asks about a case when we didn't think revision is necessary. If a baby's transferring milk well, if a feeding parent has no pain, if there's no major symptoms, the other thing that pops up sometimes is reflux. Reflux symptoms, there's some interesting studies connecting reflux symptoms and tongue ties. So severe colic, like 12 hours a day of crying, those are things that kind of send up some red flags for me too. I always encourage body work first. I'm a huge fan of osteopathic manipulation therapy. We have some really great clinics. Dr. Keller, I send people to all the time. We also have here in-house, we have Karen Mangalam, who's amazing. I think sometimes that is enough. I think sometimes babies have tightness and we loosen it up from their delivery and then they're doing okay. But then I see them again after that. Posterior tongue ties, this is mostly what I'm seeing because the anterior ties are being caught typically in the hospital. Everybody sees them, a baby cries, heart-shaped tongue, everybody knows what an anterior tongue tie looks like. Posterior ties are the trickier ones. I always assess a suck because the back of a baby's tongue needs to lift. And if it's not, they're not creating vacuum. So the front of the tongue will flick and that may not move milk effectively, may cause friction, may cause pinching. Upper lip ties, I'm torn. That's how I feel about upper lip ties. Much like Kelsey was saying, sometimes I feel like it makes a difference. Sometimes I feel like it doesn't. If they have not a ton of blanching and we can at least get that lip to neutral instead of tucked in, I feel like, and there's no other problems, I feel like we can leave it for a little bit. Increase in tongue ties, people are pushing way harder to breastfeed their babies now, and I love it. They also have social media, which is good and bad. We all know that, but they're able to kind of find some information on their own, and they want this bad. They are willing to put in the time, the effort. They're dealing with bleeding nipples, 12 hours of feeding every day. Like they're willing to put the work in, and they're going to figure out why there is an issue. I wish people knew about breastfeeding and tongue ties. I wish people understood the effect on maternal mental health this has. I could talk about this all day. I think this is a huge problem. We are squashing the self-esteem of feeding parents by telling them that feeding it must be the way they're latching. They have low calorie breast milk. They just need to feed the baby more, wake the baby every 2 hours, just pump. Just give your baby formula. What's the big deal? These are all things that my patients have been told by their pediatricians, and it breaks my heart. They're devastated. They feel like failures. They feel like they're going crazy, like something's wrong with them mentally because why isn't it working for them? This to me is the biggest impact on families, and I would say the vast majority, like over 90% of my families, I saw 17 babies this week. The vast majority of my families who end up seeking a revision have success and get to where they want to be with support and help. So usually that involves, I don't have an opinion on whether or not they have a procedure done. I'm willing to work with them either way. It's totally a parent's choice. But most people who do seek the revision, I know that's not really the word we're supposed to be using, but they seek the revision. I tend to see that usually within 2 to 3 weeks, we've had a drastic shift in how feeding is going, whether that's pain, transfer, all of the above. Overwhelmed and conflicting. This is tricky because I won't tell them what I think they should do. I know you all get this, like, what do you think I should do? I can't answer that question for them. I encourage them to take the time to do it. I encourage them to have the body work done. I encourage them to really, understand the ins and outs, talk to the dentist, talk to the ENTs, talk to the DOs, like ask and then make the decision that makes the most sense for their family. Factors in deciding, that's sort of all the same thing. It's expensive. Some insurance covers it, some won't. We have pediatricians who won't give referrals for assessments with a dentist. It's maddening. It's bananas. I don't think there's enough education around breastfeeding for doctors. I know they just don't get a ton. I used to educate the residency program in Augusta. They gave me 45 whole minutes. Doesn't really seem like enough to teach them everything I've learned in 22 years. So, but but I'm excited about where we're going. I do see people, I see a lot of tongue ties. That's the truth. But these are people who are 2 weeks out and still having problems. So that to me accounts for why so many of my patients have tongue ties. It's because at 2 weeks, most people are fine. They've figured it out. They've got it all under control. Their babies are gaining weight. And then there's a small population of people who are doing everything right and things aren't going right. And so those are the people who I work with.
Awesome. Thank you, Paula. Up next is Dr. Mike Dowling. You've got about 6 or 7 minutes. Thank you.
Great, thank you. I'm Mike Dowling. I'm a pediatric dentist in Yarmouth. I see quite a few tongue and lip tied babies. My experience with treating tongue and lip tied babies, I always kind of have to tell a story that when I was in dental school and residency, we were taught this is what a tongue tie is, this is how you fix it. But it doesn't exist. You'll never treat them, so don't worry about it. My son, who's now 10 years old, when he was born, a lot of other families were asking, you're a dentist, do you know anything about this? And I kind of stuck with that. It doesn't exist, ignore it. Then when my daughter, who's now almost 8, was born, I started to actually do some more digging and started to look at the evidence. While it's not perfect, there is actually, some studies that are coming out that do talk about improvements that we're seeing. As we referenced before, it's a fairly low risk procedure, and for the right babies can make a huge difference. And started treating some babies that really needed it, and pretty quickly saw some big improvements there. And now I've kind of become a convert to, this is something that exists that we need to pay attention to. I don't think that every baby that has a tongue or a lip tie needs to be treated. We can see plenty of them that feed just fine. We can see older kiddos that never develop speech problems or orthodontic problems or anything like that. So, does every baby that has a tongue tie need to be treated? No, but for the right kids, it can. As far as my assessment goes, oftentimes I defer quite a bit to the IBCLC that they've seen. As Paula mentioned, she spends an hour with her clients, going over feeding. She understands the mechanics of breastfeeding better than I do. And while, I do have time to talk with my patients, the assessment that the IBCLC has done, honestly, is more effective than what I can do in my time. And she has, more education in that area. I do tend to use the Hausbacher assessment tool, which does give some numerical, these are babies that could be treated and see an improvement. It's nice being able to point to numbers. Honestly, after years of doing it, some of it is, when you see it, but that does help there a bit. As far as posterior tongue ties go, I hate the term. I think it is more divisive than helpful. From a surgical standpoint, there is a difference between treating an anterior tongue tie and a posterior tongue tie. But a tongue tie is a tongue tie. If it's impacting feeding, to the family, it doesn't really matter. I don't have the study handy, but there recently was a study where they looked at essentially anterior tongue ties and posterior tongue ties. And after treatment, the likelihood of seeing improvement in feeding was no different between those two groups. So I ignore the terminology. As far as upper lip ties go, I do think that from a dental standpoint, there are benefits to treating them. We do see a lot of kids that, when they're 2, 3, 4 years old, have dental caries on their maxillary anterior teeth that in some cases we could have prevented. There are orthodontic improvements there. Also, I don't know if Cara can share the link that I sent her. We do see a lot of reflux that's linked to upper lip ties. There's been work by Dr. Scott Siegel, who's an oral surgeon in Long Island, I believe, where they looked at essentially, does treating an upper lip tie decrease reflux? And in a lot of their patients, they did see that. if we're looking at the risk benefits of treating a upper lip tie versus doing an endoscopy to, evaluate reflux or possibly medicating a baby, multiple times a day, oftentimes treating that lip tie is less invasive there. I do think it is a hard decision for parents. They're home with a, 1-2 month-old baby, and they're overwhelmed with everything. And, they're being told one thing by a lactation consultant, another thing by a pediatrician, 30 different things by Facebook, and they don't know what to do. As a couple other people have pointed out, it's our job to basically give them the information and the opportunity. And if they decide that it's something that they want to treat, given that information, we do it. There are babies that we see that don't need to be treated. And those are families that, we say, let's see how things go. Let's give it more time. If there's very rarely is feeding just one issue, although, I can surgically go after one of those causes, there's probably something else going on, which is why it's really important for them to be back in touch with their pediatrician, lactation consultant, osteopath, chiropractor. We want to hit all those.
Excellent. Thank you, Mike. I'm frantically looking for the link that you just referred to that you sent me, and I'm not finding it. So I'll keep looking. Dr. Keller, you're up. You got 5 to 10 minutes. And you're on mute.
Fantastic. Everybody hear me? I'm David Keller. I'm glad to be representing the osteopathic profession for talking to this body about this very important subject. The nature of our work is much more peripheral to what you all are doing. I don't necessarily make a diagnosis of a tongue tie. I talk to parents about it all the time, and we could talk about all those different things. My experience with tongue tie is that I see these babies when they're not doing well, very much echoing what has been said before. The parents are doing everything that they should be doing. They end up coming to me because it's still not working. The history is an enormous piece of this. My examination is very much about function. I am not looking so much at static structures, but in the dynamic activity of those structures. I do a lot of intraoral palpation and the tongue itself. There is a substantial amount of work that we do as osteopaths around the hyoid bone and its attachment specifically with the geniohyoid muscle and the muscles of the floor of the mouth. And even the digastric muscles and the muscles that come off of the back of the temporal bones. So much happens during birth trauma. And I would say that, if this was a panel about birth trauma, then I would probably be heading it up. But my role with the tongue tie specifically as it relates to this is that, as we've already kind of discussed, there's not one thing that's leading to failures in being able to breastfeed the way people want to feed. There's many things. And oftentimes, what we are able to do with osteopathic manipulative medicine is just get a little bit of extra space in there and a little bit of extra room and a little bit of extra function. Whether or not they need to have a procedure done, I do defer to my dentist and ENT colleagues. I definitely see some that I'm very strongly an advocate for. What I can also tell you, my experience with tongue tie, where it comes from, dates back even as a resident, because in the osteopathic learning, you don't consider the body a bunch of assembled organs, but rather as a dynamic tension mechanism. And as such, I've seen patients, adults who have tongue tie releases, who have profound effects through their entire body. The obvious things, singers who can sing better, people who have headaches, people who have back pain, people who have issues with posterior columnar fascial issues right down into their toes, being affected dramatically when this very primary fascial mechanism that lays right on top of our notochord essentially is released. It has influences that are far and wide. The other role that I play as the title of the businesses that I work with, hospital osteopathic manipulative medicine. We're in the hospital, we're seeing these kids early. And I can't emphasize how important that is, because babies are learners. They are downloading information at an incredible rate, and they are a changed individual every hour that they have to practice with this mechanism in the gravitational field. And I mean that in every proprioceptive sense of the word, that it really is about them figuring out, how do I use all of this? I know they've been practicing when they are in utero, but when gravity hits and suddenly those proprioceptive mechanisms are firing at the rate of 1,000 new neuronal connections a minute, these babies are accumulating all kinds of information. If they are showing up to their tango lesson with their parent, with their mom, trying to figure out how to use this equipment with their legs tied up to their back, they're not going to do that tango lesson very well. So my role, or the osteopathic role, is really to try to give them as much access as they can possibly garner to be able to do as much experimentation and do the figuring out, because babies, as you well know, do not come out knowing how to breastfeed, unlike our rodent and other four-legged counterparts. Most of them can latch right on there, have no problems. I really do want to echo what Paula said. I think the most significant thing that I see, because I deal with patients who are so distraught about this relationship that they have with their child, the mental anguish and the interruption to that nurturing connection is so profound. And I'm just so happy that we've arrived at a place where we're taking this seriously. That one, we have much more information, and yes, social media is a double-edged sword, but we have so much more information, so much more awareness, but that we have a service such as ours at Maine Medical Center, at Northern Light Mercy, Dr. Mengelam up in Augusta, going in, seeing patients early is really, 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 really a phenomenal, phenomenal moment, at least for us as the osteopaths. When I do counsel patients about getting a tongue tie or not getting a tongue tie release or frenulotomy, I do look at it from the broader picture. If they are not having problems with their breastfeeding, if they are not having problems, pain, etc., I may be less quick to tell them that they must go get this now. My experience with people having the surgical procedure is incredibly mixed, and I have a wide variety of patients. They are not self-selected who come to me. Some of them, it's an absolute home run. Everything changed as soon as they had the procedure. For some of them, absolutely nothing changed. For some of them, it made things worse. We just did an invasion in a sacred spot in this little infant's mouth. So I am anxious for an interoperator dependent exam that we can use to be able to say, this truly is not, this is posterior, this is anterior, whatever we want to call it. And I think that the osteopathic profession has a role to play in that, because we do some of that functional evaluation as well. And that's all I'm going to, the time I'm going to take, and I know that we want to have questions.
Excellent. Thank you so much, Dr. Keller. That was wonderful, really informative for me, and I think for others here. I think we heard a lot of commonalities in how folks practice in terms of focusing on function. more than anything, and also a little bit about counseling strategies, maybe that how important that is because of the impact this can have on maternal mental health. So I appreciate that that was brought up. I also appreciated how Dr. Maturo brought up shared decision-making early on. And it sounds like that is definitely something that is was a thread through what everyone was saying. So that was excellent. We do have several questions that have come through. So I'm going to start with one asking, is there a link between the lip tie and tongue tie? Like, does one go with the other? So I'm wondering if anyone is welcome to unmute and share a bit about that.
I haven't seen anything in the literature.
Okay, thank you. I think it's a great question. That's something that I think I've read mixed things about and heard mixed things about. So any other thoughts or experiences?
I mean, I think that there is a lot of social media information saying that every lip tie has a tongue tie with it. And probably as the person in this group is the most apt to diagnose a lip tie, I would disagree with the every connotation there. I think oftentimes they do go hand in hand, but it's not 100%.
I would just add that everyone has a frenulum, both a lip and a tongue. And in terms of the upper lip, and there's even less in terms of a widely accepted grading scheme. So that is even now more fraught, which is subject to interpretation.
Thank you.
From a functional standpoint, and again, birth trauma related, the two tend to go hand to hand, not from the perspective of actually being a tie, but from the perspective of being being functionally tight and reactive, compensatory strain specifically, kid who's born facial presentation or occiput posterior especially, will develop a lot of restriction through the orofacial mechanism that will also have manifestations that are more facial and perioral. So it can look like, is what I'm saying.
Okay, thank you. I'll move on to the next one. How do most families pay for a tongue tie procedure? What insurance companies will reimburse or cover? And I know this might be different based on the practice and the work that you do, but I'd love to hear from everyone who can share what you know about that.
I can share. I mean, if they have, insurance, it's billed to an insurance. It's a new patient visit, depending on how that's interpreted, 99203 or 99204. Where the average cost for that visit is probably anywhere between $150 to $300. That's billed to the insurance and depends what the insurance pays. And then the procedure itself is it's a procedural code. And that can range anywhere between $200 to $500. And depending on what a person's individual insurance is, their copay, and whether insurance covers it. Here in Maine, I haven't had much pushback in terms of insurance covering things. If I document that there's maternal breast pain or child's not gaining weight, but that's not the case everywhere. And I don't know in terms of private practice, cash pay, people that have lasers. In my area, I hear the going rate is anywhere between $400 to $900. For cash.
That sometimes medical insurance sometimes will pick it up. As a dentist, we give the family everything to file that. Sometimes dental insurance will pick it up. It's really all over the place. We take photos beforehand. We encourage our patients to get a referral from their pediatrician because sometimes that does improve the likelihood. But it's all over the place, unfortunately.
All right, we'll move on to the next question. This is for Dr. Dowling and Dr. Keller. If you could talk about how tongue ties can relate to sleep, like for instance, mouth breathing, snoring, gagging, gasping. This person who is a sleep coach, you're welcome. I don't know if you want me to share her name or not, has worked with a few clients who have had these issues, which caused very frequent night wakings, and a tongue tie revision helped resolve these issues. So what do you know about the connection with this and sleep?
I know this is a massive connection with respect to adults, especially who, this is where I've seen people who have difficulty and have adult tongue tie releases. And it's almost, I know that it is, it's just a function of that tongue getting in the way. But more importantly than the tongue getting in the way, because you can evaluate that and you can say, that's not there, that is there. It's about resting tongue tone. And this is part of the evaluation that we do with these kids when they are resting peacefully, and I've got them in my hands and their mouth is closed and they're breathing through their nose. I'll pull their jaw down, and that tongue should be adhered to the roof of their mouth. And that adherence to the roof of the mouth is created by negative pressure that they create because the back of the tongue is hitting the soft palate. It's not the front of the tongue, it's the back of the tongue. And that is sitting there. So when that comes down, I see that frenulum sticking right up like that. I know, okay, this is at least functional and doing what it's supposed to do. When the tongue is not sitting in that position, then it is free to be able to go anywhere it wants to in the middle of that airway. So I'm always asking adults specifically, or kids who can have this communication with me, where's your tongue? And so we'll even give them like little cards to put, you know, on their iPad or on their phone or whatever, some reminder like a dot or something to ask themselves, where is my tongue? And to do an assessment and to almost do a log of that to be able to determine that. And invariably, when they're saying this tongue is sitting down in the bottom of their mouth, the parents are saying simultaneously, this kid snores like crazy. He breathes through his mouth when he's sleeping. He sleeps restlessly. He's tired all the time. The dark circles, the whole bit.
I can answer that too. I don't see infants with sleep apnea. The children I see with sleep apnea are children with are children with craniofacial abnormalities. So in terms of infants, there is no association between tongue tie and sleep apnea. It's not a record. And actually, a tongue tie pulls the tongue forward, and that's when I see children with like retrognathia or micrognathia, meaning a small jaw or a recessed jaw. That's actually a contraindication to doing a tongue tie procedure, because then you can cause glossoptosis, which is the tongue falling back, and cause sleep apnea. I do not see it. I do probably 200 to 300 tonsillectomies a year for sleep disordered breathing for children in the state. I do not see a relationship with tongue tie and sleep apnea. So that's in my experience.
Thank you. Mike?
I think there is a lot there. I'd like to know more about it. You know, anecdotally, I've seen some kids that, you know, as toddlers, we did a tongue tie release and saw improvement, but that's purely anecdotal. It'd be good to know more.
Thank you. So we have a few minutes left and a few more questions. I want to address a couple of those. What is the perspective of stretching the tongue post-procedure to prevent reconnection of the frenulum? Now, this is one of those areas that you hear mixed advice.
My thought is it's not going to hurt, but it probably doesn't help. And that's the American Academy of Otolaryngology has a clinical consensus statement, and there's really probably no benefit. But with a lot of these things, if the parents want to, if it empowers them to kind of do something and feel like they're part of the process, I don't think it's going to hurt anything. But there's been no studies to show that any particular post-operative care improves the outcomes.
Thank you. And if you have a link to that statement, that would be really great to share here. If you can find it in the next couple of minutes, otherwise we can email it out. And for anyone in your practices, any research that you find, we can have this, keep this on our Maine State Breastfeeding Coalition website under our resources. We might already have that actually, I'm not positive, but Mike, did you want to add something to that question about the stretching or post-procedure care?
I mean, I have all my patients do post-operative wound care, you know, with the idea of we essentially had tissue that was stuck together. We opened it up and having it heal over again as opposed to reattaching. There isn't a hard and fast, this is how you have to do it. I think every provider has their own their own process of stretching, but
I'll say anecdotally, from my practice, I see a lot of babies who are 2 to 4 weeks out where it's a good amount has readhered. I would say most parents are not aggressive enough in the stretching afterwards to probably make a difference. And that there's not a whole lot of data that it helps, but it'd be interesting to see with adequate stretching, if we could have studies in the future that look at that.
I can't speak to the stretching, but I will say that I see families who are coming to me the first time weeks out of having a procedure done and they're not seeing improvements. And then we introduce oral physical therapy, tummy time, OMT, and learning how to use the tongue, getting that tongue moving. And we're seeing huge improvements. I will often tell families that my anecdotal experience is that the PT piece, the exercise piece, building strength and mobility after a procedure is often pivotal in how the procedure affects feeding.
Thank you. All right, one other question. I know, Dr. Keller, I appreciated you saying that you would love to see an interoperator dependent exam out there so that everyone can use the same thing. So we have one comment saying, shouldn't we correct tongue tie earlier rather than waiting for it to all go south? And also a question, how can we make assessment better or easier? It sounds like some providers do or don't have time for them. Sometimes it's out of scope for their practice, but other practitioners might depend on them. There doesn't seem to be a widely accepted grading scheme. It sounds more like the wild, wild west than I would have expected. What can we do about it?
I would agree. It is a little bit of the wild, wild west right now, which is why, like I said, I think we're having these sorts of panels. We definitely need studies to look at and a reliable way to assess tongue ties in infants. I think part of where parents get mixed messages is who's in charge of this, right? We have a lot of physicians who don't believe in tongue ties. We don't know how to assess it. Mostly lactation consultants are the expert in tongue ties, but they're not technically supposed to diagnose it. So it's a little bit of whose basket does this fall in? And I think that that's part of the reason why parents get mixed messages.
Well, I'll allow time for one more comment. I know, Dr. Keller, you're unmuted, so I don't know if you're ready to.
No.
Okay.
I don't really have anything to add to that other than I share the frustration. And I do feel like it's a little bit like this sort of wild, wild west situation because it then just begets more of that mental anguish and disconnect. It's a tough period of, you've got this newborn, you've just done all the hard work of gestating and delivering. You at least expect to be able to get the food into the child. And so it's kind of almost feels like it's this foregone conclusion that, this is going to be the easiest part. And sometimes it turns into the hardest.
Mm-hmm. And just to add one more thing too, that first couple of weeks of a newborn's life is so dynamic, so much changes, just being born, learning how to feed, so much changes. And I think that's also why it's so hard to say, oh, we need to get these kids diagnosed by 2 weeks. Otherwise, otherwise it's not going to work as well. It's just so hard in those first couple of weeks to stick a diagnosis on sometimes.
Yeah, I'd like to advocate for more interdisciplinary teamwork because I think we're not all talking to each other. And I think it's really unfair to the families when they're getting such mixed messages. They can have 2 completely opposite opinions given in the same 24 hours from us. And so we're all super busy, but more conversations like these, I think would be really beneficial to our families and then talking to each other about our patients.
Awesome. And more research, right? If you're up for doing more research that needs to happen. So maybe that interdisciplinary research project could come out of this as well. Thank you so much, everyone who is attending. And thank you so much to the panelists for making time out of your busy days to share your insights and wisdom. This has been really wonderful. And it's recording, so it will be put on our YouTube page by the end of the week. Have a wonderful day. Thank you.